You can study for the CIC exam without losing your mind, but you do need to have the right tools and the right strategy for success. What I'm going to break down today is what is covered in the CIC exam, how it is totally different from the CPC, ICD-10 CM versus ICD-10 PCS, which is the beast that you need to tackle for the CIC exam. Tips if you're transitioning from prophy coding into inpatient coding. And then I want to talk a little bit about comparison AAPC versus AHEMA. But remember, I'm not an AHEMA member, so I'm just going to touch on it. I'm not going to go on a super high level with that. So CIC stands for the Certified Inpatient Coder, and it is AAPC's credential for individuals who want to specialize in inpatient facility coding. Remember, we have prophy outpatient coding and we have inpatient coding. And when I say inpatient coding, I'm talking about billing on the UBO4 form. I'm talking about DRGs, PCS coding. I'm talking about inpatient facility reimbursement and those guidelines to an ICD-10 CM. When I say prophy coding or outpatient, we're talking about that 1500 form, okay? So billing for the provider that's doing your physical exam or your surgery or an injection versus the reimbursement that that hospital facility is going to get. And we have very different guidelines in ICD-10 CM for facility coding versus prophy coding. Now let's talk though a little bit about the exam. When we talk about AAPC exams and what's on them, they do list the majority of the categories of types of questions that they're going to ask you on their website. And I'm going to show you how to find that. So if you're on the AAPC website and you want to get that breakdown of what kind of questions are going to be on a certification exam, I think almost all of them except for the specialties do list it. Go to certifications and hit view all certifications. And then we're going to look for whatever certification it is that we are attempting to test for. So in this case, it's going to be the CIC. What you want to click next is taking the exam. And then you're going to have to scroll a little bit. So we're going to scroll past the information about the materials. And here is the breakdown of the exam. And they do list this again for the majority of the exams, especially at least all of the core credentials, just maybe not the specialty ones. So when we look down at this exam breakdown, it is the typical 100 questions. It is 4 hours long. You need the 70% or higher to pass. It is, though, a mix of multiple choice and get ready for it, fill in the blank coding questions. So you do have no multiple choice, no multiple answer banks or anything like that for some of these cases at the end. So let's kind of look down at this breakdown. The first 7 questions are going to be about the medical record and healthcare documentation. So some of these, when I took my CIC exam, I was really good with some of the categories because things like this in the med term, I already had that base knowledge of from working with the CPC and the CPMA and all of those, the auditing and medical billing and coding stuff that I've done in the past. So 7 multiple choice questions on medical record and healthcare documentation guidelines. So things like HIPAA, things like Joint Commission requirements, things like proper addendum procedures. And they're just going to ask you 7 questions out of a mix of almost any of this. Use of copy paste, use of templates. Then there's going to be 3 questions on medterm anatomy and pathophysiology. I actually lucked out during my exam because one of the questions that I had on medterm, I'm like 97% sure this is right. But then later on, I had a question that basically gave the answer. It was like, oh, this particular portion of the heart or this procedure or whatever. And then it put in parentheses what it was. And I had actually gotten a question about that earlier. So yeah, that kind of helped me out a little bit right there. So 3 midterm questions, and then there's going to be 7 questions on inpatient coding. So identifying things like computer-assisted coding and the benefits of it, correct ICD-10 CM and PCS procedural coding system, how to look up things for DRGs, the roles for inpatient coders, present on admission and use of indicators. Then we have 9 questions that are based off of the IPPS, the inpatient payment methodologies. So compliance with things like the Two-Midnight Rule, the different bill types, questions maybe even about the UBO4 form, how to calculate DRGs, the 72-hour rule, defining what a DRG is, how it gets utilized in the inpatient facility, and then things like readmissions. And then we have some OPPS methodologies, the outpatient prospective payment system, because that is still some facility related stuff. So the difference between that OPPS and the IPPS, pass-through payments, APCs, status indicators. 6 questions are going to be on regulatory and pay requirements, LCDs and NCDs, difference between Medicare Part A and Medicare Part D, ABNs, payer policies, pre-certification requirements, 5 questions on compliance. So again, if you already know some good stuff about compliance, this might not be an extra thing that you have to learn because it's about CERT and Pepper and MAC audits and internal audits versus external audits. And then there's these 7 cases, and the 7 cases are fill in the blanks. Now, they're not quite the same as Practicode, at least from the last time I was at Practicode. If I remember correctly, Practicode gave you just blanks, and it was like, here's a whole bunch of blanks and figure out how many CPT and ICD-10-CM codes there are. With the CIC exam, they will tell you how many codes you need. And there were actually some cases that it was just ICD-10-CM code. So it was like, here's this hospital note, abstract, 10 ICD-10-CM codes, and some of them it really was that many. It was many, 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 because it's realistic. This isn't just an exam that's designed to be easy to make you feel good about yourself. It wants to make sure that it is testing you on your competency to do inpatient facility coding. It will tell you like, hey, out of this case, you need 7 ICD-10-CM and 2 PCS codes. So it will give you the amount of blanks that you need. There were a couple that I was looking at that I'm like, oh man, I literally cannot think of one more possible ICD-10-CM code. And the good news is that doesn't mean that you fail that entire question. So those fill in the blank questions are on a sliding scale or kind of graded. So let's say there's 10 blanks and you get half of them right. Well, you get half credit for that question. So it would be a half credit question, or I guess a 0.5 since there's 100 questions. Each answer is weighted the same. Each case will have anywhere from 5 to 15 possible answers. Now, I know a lot of people that are CPCs, and they may have even been CPCs for a long period of time. I'm talking more than a decade. And now they're looking at learning inpatient coding. There are a lot more opportunities opening up in inpatient coding. And even I have noticed when I get notifications about openings for the on-demand coding at Code Health, a lot more of them are inpatient facility coding versus pro-fee or risk adjustment or even outpatient. So having the ability to do all types of coding right now is very, very desirable. And a lot of people want to make themselves as marketable as possible and learn all of the different nuances. But one of the biggest differences is the ICD-10-CM guidelines are different and PCS coding. So ICD-10-CM is our diagnosis coding, but even though we might already know this from working in pro-fee coding, we have different inpatient facility guidelines. So in pro-fee coding, for example, we can't code something that is probable or suspected or being a rule-out diagnosis. We can for inpatient facility. And PCS is a totally different beast. It is not something that if you know ICD-10-CM, it'll be kind of intuitive, kind of like when you know CPT. HCPCS is sort of intuitive. PCS is completely different. It's like a building blocks of all of these different components. So it is not CM. It is a different structure, 7-character alphanumeric codes, and they break down things like the body system, the root operation, the body part, the approach, the device, the qualifier. So if you're thinking, oh, I know ICD-10-CM, I kind of got this, you might hit a very big wall. PCS is a whole different ballgame, and it takes a lot of studying and a lot of practice, and even some strategies for ICD-10-CM that are a little bit different as far as what can be coded. Even if you know ICD-10-CM coding, make sure that you're revisiting those inpatient coding guidelines. So with the CIC, it's going to involve cases or coding scenarios that are more like complex surgical procedures, hospital-acquired conditions, complication and comorbidity coding, DRG assignment, and that inpatient reimbursement. So it's less about E&M and office visits and more about hospital operations, revenue cycle, really detailed documentation. One thing that did, though, save me time with passing the CIC exam is that I had that strong understanding of ICD-10-CM. So my strategy for this exam was I'm going to go through and answer all of the ICD-10-CM portions of the exam, skip the PCS portions for later, because I figured, oh, well, I might need some more time for that. For example, some of the cases I had 7 or 8 blanks for an ICD-10-CM response and only 1 or 2 PCS codes. So what I did was I answered all of the ICD-10-CM codes, flagged it, and then came back at the end and then worked on the PCS portion. So that way I wasn't flipping between ICD-10-CM and PCS. I just did all the ICD-10-CM, had my ICD-10-CM book out the whole time, tackled all of that, and then tackled PCS. Because again, if there were 8 ICD-10-CM codes and 2 PCS, I had a higher chance of getting higher partial credit if I got all those CMs right, even if I missed maybe part of the PCS. And really, that helped me more efficiently navigate through the exam. And it was just really, really critical for me to understand that exam platform. That was an absolute lifesaver for me. So please, 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 if you're going to go into this exam from any aspect, someone who's transitioning into inpatient coding or someone who's brand new to it, you have to understand that exam platform and have a good strategy going in for this exam. So if you are a CPC and you're looking to add the CIC, first of all, go you. I love that for you and your ambition. But a couple of things to keep in mind. Get comfortable with the inpatient record, with discharge summaries, with operative reports, with nursing notes. Spend a lot of time learning that PCS coding structure. CM and PCS are apples and oranges. Learn that inpatient reimbursement system. This isn't about line item billing. It's about the grouping of the services under the DRG. It's about that UB04 form. Get familiar with abstracting complex charts. Like those practice exams through the AAPC were one of the biggest helpers that I had. Like going through the study guide and the practice exams, that was so, so critical for me. Now, there are some things that are going to be very similar to the CPC in regards to MedTerm and compliance. So if you're really, really strong in those areas, you've already got a small chunk of your studying done there. Some of the questions that I encountered on the CIC exam, I was able to pass because I had that pre-existing knowledge from my prior studies and prior experience in other areas of billing and coding. Now, of course, a lot of people ask, is it worth getting the CIC from the AAPC, or should you just go for the CCS from a HEMA? So here's my take. The CIC from the AAPC is focused entirely on inpatient facility coding. The CCS through a HEMA covers both inpatient and outpatient facility coding, including hospital-based outpatient services. Now, I'm not an HEMA member, so I'm not here to promote or critique their credential, but that's the broad differences. I will say that a HEMA has had some difficulties lately. It's been more difficult for members to submit their CEUs, make sure that they're maintaining their credentials. There's been some financial issues. So if that's something that you are concerned about, I would definitely do some more research in there, talk to some people who maybe are HEMA members, because they have been having some struggles lately. And I do hope that they overcome them, but it is certainly some factors that have been deterring people from a HEMA and joining a HEMA as a member. Having said that, of course, we also have to consider, are employers going to accept the CIC for inpatient coding positions? From what I've seen, they are really starting to accept the CIC for inpatient coding positions. If anyone else sees anything different, though, definitely let me know. But it's been around long enough now that most of the job postings I'm seeing are saying it has to be the CCS or the CIC from AAPC. But here's how I would kind of recommend you study for the CIC. First, get solid inpatient coding training. Don't just rely on your CPC prep, because it's not going to help you. Most medical billing and coding programs are not focused on inpatient coding, or they maybe only cover a small portion of it. I know maybe like a chapter at the very end. So if your program did not cover ICD-10 PCS, it's not a program to prep for the CIC or for inpatient coding and other similar credentials. I really liked using the AAPC materials. I also liked having Speechify read the books for me because it helped me absorb them a little bit better. I like that feel of that immersive reading, and it was really beneficial. And if you're interested in learning more about Speechify and how it can help you with reading your books faster, check out my affiliate link in the description. Also, make sure that you are using inpatient charts to practice with, like the ones from the official AAPC practice exams, and really take note of what you're not doing well with. For me, when I was putting together those PCS codes, I tend to have one digit that I'm off on, and I was able to go through back with my rationale and figure out where I made that mistake. So really drill those PCS tables and the guidelines until they're like second nature, and practice fill in the blank questions. That is a big part of the exam. And know that online exam platform, because this is one of the big things that helped me on exam day, was being able to skip certain questions and come back to them and making sure that I was confident in navigating to the exam. So going to the content section, finding all of the breakdown of the questions that I flagged, and then going right back to them before I accidentally hit submit and didn't have the chance to. And most importantly, don't rush it. This is a really advanced credential, and you want to give yourself the time to truly master the material. And if you found this video helpful, don't forget to like, share, and subscribe. Drop your questions in the comments below because I love helping to navigate people on their certification journey. So thanks for hanging out with me. As always, I will see you in the next video. And until then, just keep on coding on.